See you.
Okay, good afternoon all, and good morning for those in the diaspora because of time difference. I'd like to welcome us to the September meeting for our group, and today looks to be, it's going to be exciting. We have a special guest, Professor Anang, who is going to talk to us about the benefits of leveraging the 12-pillar clinical governance program in private medical practice. So without wasting much time, I would like to hand over to our chair for his opening remarks. I hand over to you, sir. You are muted, sir.
Okay, thank you. Am I audible now?
Yes.
Okay.
Very well.
Okay, great. Yes. Okay. So thank you, Dr. Eletu, and I join you in welcoming everyone to the meeting. Our very senior colleagues, Professor Genge, Dr. Ajini Fuja, and all the others, and especially our guest speaker, Professor Joanna, who I've known for a very long time. And he is an expert in the field of today. So there's no better person to treat this topic than him around this place. And we also have with us one of our members who is also an expert in this area. That is Dr. Onifade. This meeting is a very important one. Especially with regard to establishing and maintaining and improving the quality and standards in our practices. And it's one thing for the head of the practice, in this case, pediatrician, to know all the right things to do and to do things correctly. But more often than not, we find situations where there's challenge in, ensuring that every member of the team does the same thing in a standard fashion and improves the quality. And then when there are changes, where there are innovations, which the leader is aware of by virtue of his or her own exposure, how is this cascaded down the team such that every member of the team is doing the same thing in a consistent way? And we know that the British system, the UK system, has perfected this place. I do not know of many other places in the world that can beat the UK in terms of standards and orderliness generally. So it's a pleasure to have somebody who has that background and who has a mixture of being in Nigeria as well and leading teams in Nigeria, and in fact, all over the world. So I won't say too much. I think the moderator will have more to say about him. So I welcome you and I look forward to a very interesting meeting. Thank you very much. Over to you, Dr. Eletu.
Thank you very much, sir. And just before I hand over to Dr. Onifade, our moderator for today, I would like to formally welcome Dr. Femi Peter. I think she's joining us for the first time on this group. So welcome, Femi.
Thank you very much. I feel very honored.
Thank you. So Dr. Onifade, I hand over to you officially, ma'am.
Thank you very much. Good afternoon, everyone. I think it gives me the greatest pleasure and honor to introduce Professor Joseph Anang this afternoon. He's our eminent speaker for today. I was having a chat with him over the weekend, and I found out we had a few things in common, which was quite interesting. One of this is the fact that we graduated the same year, but unfortunately, he went to the #3 university in Nigeria. My league table And the Universal League Table, I believe, says the College of Medicine of the University of Lagos is #1. Hold your breath, Ibadan graduates, don't get angry. But that was before we had the plethora of medical schools in Nigeria. Then he went on to do the statutory training in house job and, and the National Youth Service Corps. House job was in Calabar, and National Youth Service Corps was in Bauchi. And then he stayed on in Bauchi for a few months, thinking that they would train him, but it didn't happen. So he went back home. He went back to Calabar. And he was amongst the first set of trainees, residents in Calabar at that particular point in time. He started his training in general surgery. But again, you know what it's like. I was listening to the radio today and they said something like Dakpa. That means he moved. He moved to the UK, where he completed his training and got the FRCS in general surgery. Then he went on to do a diploma in urology. So he became a urologist. And then he thought about his homeland and thought, I should come back to my homeland. And he came back. He got a locum job as a locum consultant. But we all know what Nigeria is like. There's a lot of politicking around here. It didn't make him comfortable. So he went back. He went back to the UK. And when he went back to the UK, he decided to set up a GP practice. But again, he had to retrain as a GP. So he set up this practice, a GP practice with special interest. So his special interest, as you all know by now, he's a urologist, he's a general surgeon. He also took up a job with the Luton and Dunstable Hospital. All of this was in South Bedfordshire in the UK. He became a trainer for Luton and Dunstable NHS Trust. So his mind never left Nigeria. He, along with his colleagues, set up a charity which they called Nigeria Medical Forum in 1991. And the job of the young guys was to find medical literature, medical books for colleges of medicine in Nigeria. And they got books from, quite a few NHS hospitals, including the Royal Free and St. Mary's. And they brought these books to us in Nigeria. Some of the beneficiaries included his alma mater, where he trained as a resident, or where he began his training as a resident, Calabar. But he even went as far as Sokoto to give them these books. In addition to that, he collaborated with the BMJ, or BMA, that's the British Medical Association. And they started to introduce the BMJ journals to Nigeria. He was on the board of editors of the international edition of the West African BMJ. That is interesting. So this man is not just a doctor, he's not just a trainer of trainers, he is also interested in improving medical education in Nigeria. So in 1998, the late 80s, was when clinical governance, which I will refer to as CG from now on, became popular in the late 90s in the UK. Everybody started talking about excellent care. We started talking about standard care. And he, again, was one of the first people who got a training and certification in clinical governance in the UK. He then became the clinical lead for CG in the South Bedfordshire region. And that was between 1998 and 2004. Again, boom, came calling. He's an educator, he's a doctor. Now he's about to become a manager. Donald Duke, the then governor of Rivers State, recognized the germ they had that was hiding away in diaspora. He had heard about all the workshops that Joe came to organize in Nigeria. Donald Duke sort of wooed him back to Nigeria and made him his commissioner for health. That was a massive opportunity for Joe, and he never let opportunities slip by. He took that chance to introduce clinical governance locally in Cross River states, and then nationally in Nigeria. He knows the names of all these big organizations in Nigeria where he was talking to them about clinical governance. Joe, in his capacity as health commissioner, like I said, was able to introduce CG locally in Cross River and in Nigeria. There's so much to say about him, but I'm going to eat into his time if I keep talking about him. He has told us he's going to talk to us about the 12 pillars of clinical governance. I had only heard of about 7 pillars of clinical governance. So there's just
I think we lost Dr. Onifade briefly.
Yeah.
So we would like Prof to kindly go ahead with his presentation. She will wrap up when she
so enjoy and listen to him. There's so much to learn from him. Thank you.
Thank you very much. Thank you very much, Dr. Elizabeth Onifade. From now, we'll call Lisa, for that wonderful introduction. Let me try and share my slides. There we go. Are we able to see my screen, please?
Yes, we can.
Thank you very much. Let me just go straight on. I want to start by appreciating the group for inviting me to give this talk. It's really a real privilege and honor to ask me to do this. And I want to say that the way that you successfully made sure that I'm here today shows that the group is already on the road to clinical governance. Dr. Olufemi Mobolaji Lawal, we first met in 1995, and as Lisa has told us, that was the year that I co-led a delegation of the Nigerian Medical Forum and the BMJ to Lagos, Nigeria, where, of course, at that time there was no Abuja, so Lagos was the seat of government. Dr. Chayinde Eletu has been constantly on my back to make sure that I'm here today and that the program runs well. And in fact, earlier this morning, something very rare that really happened took place. He got one of his staff, one of your staff, to arrange a testing session with me. That was wonderful. And Lisa had just told us anyway that we had a chat a few days ago. And I want to say thank you too for having me, all the members of the group. And I must say thank you too to my co-promoters of 12 Pillar Clinical Governance Program in Nigeria, both past and present. And then I must appreciate all the sources from which I've gone to get ready for this talk. I'll try and keep it very short. It's not easy to compress almost 32 years experience into 40 minutes, but I'll try. The objective here is I would like to tell a story about how we came to develop a homegrown quality tool and how we use it to strengthen the whole health sector and system in both public and private sector. And hopefully we should all be able to do the same if we get to do the things that I'm going to talk about. And the topic, as we've been told, is the benefits of leveraging the 12-pillar clinical governance program. We run the HRI Global owns the Center for Clinical Governance Research and Patient Safety. We're based in Calabar. We cover the world from Calabar, Nigeria. And we have an international multidisciplinary faculty. This slide just tells briefly what Lisa has just gone through from when we started our interest in strengthening the health system and sector for our country, Nigeria. So I won't go through that again. But let me say that the highlights for us is, as you can see from that slide here, that from 1990 to 1996, there was a huge collaboration with the British Medical Journal and the BMA. And because we saw that we had common interest in taking health information and education to less privileged parts of the world, including countries like Nigeria. And in 2002, as the internet was just beginning to arrive, we set up a health information resource center in our base in Calabar. That was essentially bringing paper information and electronic information to the same room and made it possible to have access to the global information that was available at the time. And in 2004, as you've been told, I came back to Nigeria at the instance of Governor Donald Duke. Actually, he's of Cross River State, not River State. And going forward with our whole aim of HRI Global, the 12-pillar clinical governance focus is on the whole health system and sector. But in 2015, we had an opportunity to collaborate with the University of Cape Town, Knowledge Translation Unit South Africa, to introduce to Nigeria PAC Nigeria program, which focuses on primary health care. And PAC stands for Practical Approach to Care Kit. That's a different topic for another day. Now, the background to this talk is that I just picked up a number of quotes from the UNDP, United Nations Development Program Global Center, which highlighted, since I'm talking to a private practitioner group, I think this slide will be important, relevant to what we're discussing. That in many developing countries, the private sector plays an enormous role in the provision of health services, such as in Nigeria and India, where 70% of services are provided by the private sector. Evidence from low and middle income countries suggests private provision is more efficient than public provision, but it is more expensive. And when you now look at a country like ours, for the past 2 years, we've been labeled as the poverty capital of the world. Begin to see that there is need for us to do something about this. And private providers often have better efficiency because of more recruitment autonomy, lower pay levels, and market-like operational conditions. Essentially, as private providers, we have more autonomy, less bureaucracy that tends to delay things from happening. The bureaucracy that encourages nepotism and all the other things that ensure that we don't have the right caliber of staff, for instance. Yes, the pay is lower because some of our colleagues probably think it's to their advantage to employ lower skill or in fact unskilled persons to do skilled jobs, which turns out to be penny wise, pound foolish, because you can never run a quality service with that kind of level of staff. Then private facilities have short lifespans in most cases. They do not outlive the founders. And this has a very important relevance to our environment. The last time I was in Calabar and I looked around, most of the private clinics and hospitals that our parents used to take us to when we were growing up are no longer there. And you will see as we go along why this is the case. And we'll hopefully, if we imbibe the clinical governance messages, we should be able to have practices that outlive us and still continue to deliver quality care. Now, this, the health situation analysis. When I came back to Nigeria in 2004, as I said to my boss, the first thing I wanted to do was to find out what was on the ground, what was the situation analysis. And I now thank God that I did, because before that, for the previous 10 years or so, we had been running training workshops in Nigeria and Ghana twice a year. And so I thought I had an idea about the health system. What I didn't realize was because we were running these programs first in Lagos, and then when Abuja came in Abuja, and places like Calabar, which was the state capital, and then Accra, the national capital of Ghana, and then Kumasi, another big center. I didn't quite understand. So when we did this situational analysis, here was what we found. In 2004, there was no health law. The national health law was not there. And that was lacking. And that meant the system really had no clear vision or mission. There was no, Nigeria had at that point about 10 development plans, but really, they were not really smart, and they were not enabled by law. Then funding. At that time also, there was no health insurance scheme, national health insurance scheme, which sadly, even though it's been established for the past how many years now, 12, 11 years, it still hasn't made its objective. But at that time, there was none. So there was not a steady flow about how the health system was going to be funded. And for the private sector, most practices depended on the owner's savings. And because there was lack of structure and it was difficult to access money from other sources, then infrastructure was generally poor for access, and when the patient gets there, the flow of patients within the facility was also very poor. The maintenance culture was hardly ever there. And I need to emphasize that these findings were not just in the public hospitals, they were also the same in the private hospitals, because we looked at both. We looked at both the government-owned hospitals in Cross River and the private facilities that were in the States at the time. There were about 100 of them. Equipment, again, lack of appropriate equipment for the level of care that a facility wants to deliver. And for the private facilities, the more advanced equipment was really too expensive and out of reach for them. Where they had some equipment, maintenance was virtually not there. Then the utilities, sanitation and the ambience was very deplorable. There was hardly any 24/7 provision of water, potable water, light. The environment was really very unsanitary. And in one case, I remember we said to the government, we think this place should, even for a veterinary practice, it will not be adequate. Then for staff and the staff management, there was low numbers, very low numbers. We had some hospitals of about 60 to 80 beds with one doctor. And if you take that to the private sector, most of these private clinics were single-person clinics, single doctor clinics. And their staff were generally demoralized. And as we said before, pay was quite low. And the whole system, there was really lack of focus on providing safe care, information and ICT. Most of the facilities had no provision for facilities for their staff to upgrade knowledge and keep up to date with their local colleagues or colleagues elsewhere around the globe. There was hardly any facility that was doing audit. And surprisingly, 2 years ago, we're looking at the Nigerian Medical Association, we're looking at rolling out some audit program. And we found that even within the teaching hospitals that we have, some people, a majority of doctors still see audit as a measure by administration to catch you out, not as a process of improving care. Then patients, there was hardly patient review, but the ones we spoke to at the time were generally dissatisfied. They were exposed to the risks from these unsanitary places called health facilities. And there was a lot of bad behavior by the staff. So patients tended to come to hospital as a last resort. And of course, by the time they come, they're already complicated. Not only is it bad for the prognosis, it's also bad for the cost of care. So these are the key things we found. And then the items, clinical effectiveness, audit, risk management, education and training, and patient and public involvement. These are the items that the 7-pillar clinical governance talks about a lot in the developed world. But we'll come back to that in a minute. So following our needs analysis and situation analysis in 2004, most facilities were not viable and they were failing to deliver quality or safe care, whether private or public. I'm moving now. Okay, and on the clinical side, what we found, since I'm talking to pediatricians, I thought the second column from the left, which we're all very familiar with, we're struggling with every day, the things that kill our children. And then the last column talks about the non-disease causes of poor healthcare in Nigeria. The key of it is to the patient is the bad attitude and behavior of the health personnel, followed by all the others: infrastructural decay, non-functional equipment, water, light, and all the ones I've mentioned earlier on. Now, this is very important. My personal experience, I was 2 months in the cabinet in Cross River State of Donald Duke. The governor himself brought a memo He wanted to improve welfare for teachers and for the health workers. I was the youngest by tenure in the cabinet. Every other member of the cabinet resisted Mr. Governor's memo. They said, no, the teachers can have it, but not the health workers. The governor said, why? They said the health workers, actually, it's horrible. You don't find them there. The hospitals are smelly and all sorts of problems that we discovered during the situation analysis. So that's why that's the bad attitude and behavior of health workers is key. Now, if you go even further, our country continues to punch below its weight in health. Whether you're looking at maternal mortality or infant mortality or under 5 mortality, well, compared to our fellow sub-Saharan Africans, we are not doing well. You extend it, you look at the skilled birth attendants, antenatal coverage, immunization coverage, under 5 mortality, we're not doing well. And to make it worse, the inequity in the delivery of service. You'll find, see in this graph, for instance, how comparing the poorest 20% of the population to the richest 20% and see the disparity, almost a 10 gap difference in all those indicators. So this was what we found. We now had a challenge because I had won the heart of clinical governance lead for a county in England. I had 2 options in 2004, go back to the UK or stay back in Nigeria and see if we could do something. I said, well, okay, maybe we should bring clinical governance to Nigeria. But obviously it was very clear to me that we couldn't bring the clinical governance as practiced in England or any other Western country, including America, Australia, Canada, and the rest of Europe. You couldn't just transplant that to Nigeria, given the specific gaps that we identified. So we needed to do something. And this is why without the slide in front of you, you will see two charts. On the left is Professor Liam Donaldson's 7-pillar clinical governance of 1998, of which, as we've been told, I was one of the first 40 clinical governance leads trained to administer that in the UK. So in 2004 in Cross River State, the ministry took the view that for us to be able to deliver these 7 pillars on the left, we needed to get certain structures on ground. We needed to have a state health plan underwritten by law. We needed to have a funding mechanism to ensure that whatever we're planning to do, we're able to do. We needed to make sure that there was appropriate equipment depending on the level of the care that the patient is attending, whether it's secondary care or primary care. Cross River State, I think till now, doesn't have a state teaching hospital. So it was secondary, or University of Calabar Teaching Hospital is federal. So we didn't have any control over that. Then we needed to make sure that physical infrastructure and the utilities and ambience was appropriate. And without these 5 pillars, it was not possible to deliver the lower 7 pillars, not possible. You couldn't talk of quality without those 5 pillars. And that's how we came about. We coined the 12-pillar clinical governance and went ahead to pilot it. And you will see the results later. Now, we needed to be able to define this so that we could sell it to our political colleagues who hold the purse strings. It was very important. So for us, the 12-pillar clinical governance is essentially about protecting patients and supporting health workers and doing both in tandem. Yes, it's proper that we must protect patients, but it's also proper that we must support the health workers to be able to protect the patients. And that for us was a definition of what we're trying to do. And it was very easy to explain that to our colleagues, our fellow policymakers. And then to emphasize that the clinical governance is not just about the clinician. It's not just about the doctor particularly. It's for everybody, whoever is involved in patient care delivery, from the gate man to the mortuary attendant and those in between. They have to get involved. So we set up a multidisciplinary, multi-specialty, and multi-sectoral system. So that's where we are. So we crafted, and so the policy and law, the funding mix, the infrastructure, equipment, utilities and ambience, staff and staff management, patient and public involvement, information and ICT, clinical effectiveness, clinical audit cycle, risk management, education, research, and training. Those are our 12 pillars. And for pillar 1, it's important. We discovered that most colleagues think that when these policies are made, that they are only for the government hospitals, but that's not true. One of the reasons that the facilities, private facilities, don't outlive the original owners is because they lack the structure that enables that to happen. How many of our private facilities have an independent board that can speak truth to power, that can talk to the owners of the facility? In the management that comprises specialists in the various areas, whether it is in the finance, whether it's in the operations, whether it's in the clinical establishment of standard operating procedures and quality matters. Is there a balanced scorecard to make sure that you measure the performance of everybody who's involved, right from the board, independent board itself, to your management and to the operational level? Because at the end, as we will see, quality pays, but it is not a given that you probably have a written manual. Doesn't mean that you deliver quality unless you make sure that you have structures in place for it to happen. Reducing mortality and morbidity, making sure that the patients are happy so they can use the facilities, making sure that there's security, and making sure that there is an evidence and empathy-driven administration. Without the funding, it is difficult to translate any vision or mission into practice. So it's important, especially in our profession, where we want to do the best for our patients, but we also want to make sure that the facility survives. So there is a need to balance your books, but in fact, from our experience, as you will see, if we can deliver quality in our various practices, the books are easier to balance. The growth comes easily. The access to funds becomes easier because you can convince whoever the investor is going to be that, yes, your patient flow, your patient numbers can help you to meet whatever challenges you're meeting financially. If you become clinical governance driven, it's for the success of quality outcomes. So quality pays. It is not a good idea to depend on owner finances only, but that's a misgiven. We need to find ways to buy into what exists now in the public sector. For Nigeria, it is the National Health Insurance Authority, as it's called today, and the Basic Healthcare Provision Fund. How do we access that? And I can tell you, unless there is evidence that you are delivering quality, supported by you implementing those quality frameworks that you've established, you may not be able to take active part in those and access those funds. For Pillar 2, the utilities and ambience qualities, how many of our private hospitals can guarantee 24/7 potable water, 24/7 electricity of any form, whether it is the national grid or generator or solar, whichever form? A lot of us think that it's too expensive to do those things, and they will try to cut corners. But if you don't have these functionalities, it is difficult to deliver quality care that will satisfy your patients and make sure they have a good patient footfall. How many of us make an effort to modernize our processes and the equipment that should help us to deliver this quality care we're talking about? In the picture here, we're looking at the midwife trying to listen to the fetal heart. We can see one with the ancient fetoscope. If she has earwax, she's not going to hear nothing. The Doppler can help. I'm going to move faster now. Again, we talked about the infrastructure and equipment to address those challenges that we saw during the situation analysis. And because we're looking at whole sector, the emphasis came from before the patient gets to the facility. What's happening in the environment? Some of us would remember Calabar Clean and Green, Cross River Clean and Green. And this was all part of it. With the clinical governance being introduced in Cross River State, the government established a health in all policies policy. There was no government major activity that did not have a health subcommittee, none. From building the Budokato Ranch to building the cable car to the Tina Power project, to Calabar Carnival, to the Christmas Festival. And this was why we literally had 0 casualties in all those major international events, including the Obudu International Mountain Race, where we used to have 42 countries take place. There was an efficient ambulance service that the public could call for an ambulance at 2 a.m. in the morning, rather than the parents of a 5-year-old or 6-month-old baby trucking the place in the night. The ambulance will get to you anywhere in Cross River State. And we made sure that the ambulance carried patients. They were not used as hearses. Equipment, yes. The picture here shows us for the advanced equipment, because after Cross River, we scaled up clinical governance to other states. This was in Bauchi Specialist Hospital to assist advanced diagnosis. So essentially, this chart shows those pillars that differentiate the 12-pillar clinical governance from the 7-pillar clinical governance that is practiced in the West, in the richer countries. There must be clear-cut policies and procedures and the law that underpins it. There must be a clear-cut way of how to finance it. And of course, there must be the utilities, which is one of the bane of our health facilities, public or private. And then the sanitation. It really saddens one when you go around the hospital and it's looking like a waste dump. So in practice, we compress these 12 pillars into 3 subheads. the standards where we have the quality frameworks and standard operating procedures that are mandatory and have to be followed. And it has advantage in using that. We'll come to it. The risk management and good medical practice checklist. And of course, the results-based monitoring and evaluation, which includes the clinical audits and the research. And for education and training pillar, it is mandatory. It was mandatory, as I said, from the gate man. They had to be trained to do their work properly. Those in the middle, the clinicians and the porters and the administrators have to be trained to do their work properly. Remember, we're trying to create a new culture, the culture of quality. And we cannot create the culture of quality when the whole totality of the staff are not engaged. So they have to be there. And we had a lot of support to do this. And then our staff and staff management pillar is underpinned by what a statement that we made in 1995, where we told the government of Nigeria at the time and the Nigerian Medical Association that no matter how beautiful the buildings in hospitals and health facilities, and no matter how sophisticated the equipment, the critical factor in delivering quality and safety, preventing and reducing morbidity and mortality, is the attitude and behavior of the healthcare providers, their knowledge, their skills, and their expertise. You get that wrong, and everything falls apart. And this was very important in getting our colleagues in the policy-making arena to really understand what we're driving at. And we've already emphasized that clinical governance involves everybody and leads you to a functional facility that is viable, because you would see we were able to reward. We had a system for rewarding and sanctioning. We rewarded good performance and sanctioned repeated failure. Clinical effectiveness also digs into the culture, the effort to build a patient safety culture. We want to make sure from the Center of Clinical Governance that we had at the time that every measure that was introduced through the quality framework was fit for purpose and relevant to our context. And those pictures there just illustrate the training that was done. In 2006, as early as that, we were able to introduce endoscopic surgery and investigation in Cross River State General Hospital, not the teaching hospital. And this is one of the areas that caused a lot of problems in the health system. Rational drug prescribing and drug use, and the multiplicity of drugs per condition, and leading to confusion and difficulty in controlling this very important aspect of running a health facility. Out of stock was rife, so we banished it. It was eliminated as soon as we introduced the Essential Drugs Program. All drugs were NAFDAC approved, supplied by at the time there were 10 major pharmaceutical countries in the country who were all subscribed to this. And then every drug had a long shelf life, minimum 2 years. And of course, generic prescribing was enforced. So those were the three objectives of having this program. But within 1 year of implementing it, the Essential Drugs Program was making profit. We did that in partnership with one of the drug companies, I won't mention them. And once the profit started coming, the state government was very pleased. But more effectively, it meant that patients when they get a prescription from a consulting room, got their drugs from within the same facility. It makes sure that we knew the quality of the drugs that were being given. It makes sure that we knew that those drugs were in stock, and the generic prescribing. Then the patient and public involvement. Remember, during the analysis, the patients had told us that they were not happy with the services they received. And I had had a shock introduction in the Executive Council, where all my colleagues were against welfare for health workers, even as they approved welfare for teachers. So it was very important that we carried along our patients and the public in showing that we were going to transform the system, and the system was being transformed. And part of that was making sure that the extortion that is fairly rampant in hospitals in the country, including private hospitals, is taken care of. So patients knew exactly what they were going to be charged, and that they were not extorted. Importantly, to reduce the violence against health workers, patients, there was a public education in collaboration with the Ministry of Information and Education. But patients' rights, told them what their rights were. But they also had responsibilities to make sure that the health worker feels safe to be able to protect them. So equitable care, patient and family awareness and satisfaction was very, very important to us. And in fact, I said to them that you are our first priority. But for us to be able to deliver the kind of care that you say you desire, stop violating our own rights as well, because we have rights too as health workers. Then the risk management, this is very important. This cuts across really the other 11 pillars, from making sure these processes make sure that, as I said before, that there are guarantees from the policy level to the implementation, to making sure that the funding is achieved, and that the environment is conducive and ambient for delivering care. Those standards we mentioned about will build capacity on a repeated and a cyclical basis. Employed more staff, more skilled staff particularly, and make sure that the distribution across the system was equitable. And the reward and sanction regime was very useful because initially we started with making sure that those staffs that have not been promoted for a long time, for instance, if you had no record of misbehavior in your file, you automatically were promoted. And that was very useful to get the staff to cooperate with this new ethics, this new work ethic that was coming in. And then to make sure that they complied with the standard operating procedures, because this was new to them. They had not worked to those standards before. So it was very important. And they emphasized that the guidelines and the frameworks were evidence-built, informed, and educate them on what that meant, and thereby introduce some basic research methodologies at every level, both the clinicians and the non-clinicians. Part of it is if you follow the Nigerian Medical and Dental Council reports, for instance, you'll notice that over 90% of the cases that go before the council is related to surgery. So it was important that we hooked the state, wherever state we're publishing, whichever facility we're working with, whether private or public, we hook them onto the WHO safety in surgery checklist and make sure that that is implemented. And as the WHO will tell you, and from our experience, the incidence of accidents from surgery drops by well over 80 to 90% within a very short time. We also have the standard operating procedures and frameworks for all these conditions, all these situations listed here. But importantly, if we're going to have an effective audit system, then there must be a disease register, because it makes the work a lot easier and less cumbersome for anybody who wants to do some kind of reflection, which is audit, or do a research into any of these topics. Now, the picture on this slide has been put there. It's actually from a private hospital. At the time, you could see that was supposed to be a patient undergoing theater surgery, and the summary is that this is not a recommended theater practice. You can see the exposure there. I'm rushing now. And then finally, the information, at least there must be some provision for staff at every level to be able to update their skills, compare what they are doing with what their colleagues elsewhere are doing. And this really doesn't, these days doesn't really cost much, because just one room like we had here. This picture was in the General Hospital in Calabar. It used to be a warehouse, and we have just converted it to the Health Information Resource Center, combining both textbooks and reference books and internet connectivity, and make sure that that was available for staff to use free of charge and on a 24/7 basis. So even out of hours, people can go there and do useful work. And then the audit, in our books, no audit, no quality. If we must be able to find time, as busy as we are, we must be able to set out some time to reflect on what we're doing or what services we're offering to the patient. Absolutely key. That this is embedded as part of the culture of the health facility. And the benefits, just a small list of some of them that came very, very quickly. And before you knew it, awards were pouring in from within and outside Nigeria. Remember, we had said, for us, the 12 Pillars of clinical governance is about protecting patients and supporting care providers. In tandem, you do both together. And very quickly, those patients who were complaining, they now said, yes, their service is faster. For us, the service is also more efficient, more responsive, of high quality as shown by the audits, and was consistent. Consistent because we had a standard operating procedure for various conditions. So whether you were seen by nurse A or nurse B, or Dr. A or Dr. B, the care is more likely to be consistent because we are reading from the same hymn book. And then there was equity, making sure that your care does not deliver on how deep your pocket is. And that was enforced. And then patients generally almost between 95, 100% satisfaction after 1 year of introducing this. And then for those of us who are in the private sector, quality pays. Your EBITDA, earnings before income tax, and it increases. And those in private sector will understand what this means. We're all in private sector, so we know what that means. So whatever we think we're spending to achieve this quality ensures that our practice becomes viable and can outlive us. Then under supporting the caregivers, attitude change, CPD was mandatory, and the training and retraining of skills welfare package, effective self-regulation. The welfare package, let me give you an example. In the third year of implementing this program, the Cross River State health workers were paid equivalent to their colleagues in the teaching hospital. That was simply because when they had demonstrated that the service was delivering on its mission and the vision that the government had set for it. So whether it's private or public, quality does pay. And there's a lot of validation for this concept already. You recognize some of these faces. Yeah, you see Mr. Donald Duke, my governor at the time, and then the former ministers and Minister of State, and importantly, a former president of the Nigerian Medical Association. He established the Clinical Governance Committee of the NMA in 2012, which is today a standing committee. So all these ministers had one thing in common. They all said that Nigeria needed clinical governance, and it was validated. The memos relating to it were validated by the National Council of Health in 2006 and 2007. And that's too much lives to go. This was the Calabar Women and Children Hospital. This was the first private hospital where we scaled up the 12-pillar clinical governance in 2009. And within 1 year, it's achieved the ISO 9001 accreditation. This is Lily Hospitals Limited, based in Warri, with a branch today in Benin. This was on the left side is Lily when we started with it in 2011, and this is today this is the Warri Annex, and the Lily Hospital has achieved the COSASA quality accreditation and the ISO 9001 since 2015. COSASA of South Africa, because Nigeria, as we speak, still doesn't have a national standard for this work. So we have to go outside the country to get it. And incidentally, South Africa is the only country in Africa that has an equivalent accreditation body that you can compare with NICE of UK or JCO of America. And another hospital, Capital Health Clinic, based in Warri, ISO 9001 quality accredited. So the take home is that the 12-pillar clinical governance program is homegrown and is suitable for lower middle income countries like Nigeria. It is suitable for both private and public health system transformation. The value is in aligning clinical, operational, and executive leadership using the program. It's a win-win-win for the patient, for the practitioner, and for the system. Quality accreditation for clinical governance is achievable once you can apply the system and make sure that it is consistently applied by your staff. The facility is guaranteed to outlive the first owners, and they will continue to deliver quality care. The hospitals I've told you, like Warri, Lily, for instance, Lily today is one of the top most private hospitals in the country. We started from a few hundred million, it's now a multi-billion naira hospital. We have about 6 books on this, and the whole system change of failing health systems. It describes exactly what was done in Cross River State during the pilot, and the tools for implementing the program is now in the 2nd edition. The 2nd edition is in print, and I want to thank you for giving me the opportunity to tell you a story about what we came to see and what we did. Thank you very much.
Thank you very much, Professor Anna. I could listen to you for a whole day. I now clearly understand why you have 12 pillars. In a country where the government doesn't have a system, you have to help the government put in a system. And that's where your first 5, that's where your additional 5 pillars came into play. I just think that we need you. The Yorubas have a saying. They say, what you're searching for in Sokoto, you've gone all the way to the north to look for it. It's bang in the pocket of your trousers. So I was sitting in the UK for the past 6 months, trying to get organizations that were set to come to Nigeria to help us. You are here to help us. We should use what we have. I am so grateful that you agreed to give this talk. I am happy that you have taken your time to take us through the pillars of clinical governance. I understand clearly that clinical governance is a way of life. It is something I have learned to live with in the UK. When I first got there, we used to say, oh, these people, they like buzzwords. They don't like buzzwords. They like things working well.
Yeah.
And the only way we can make sure that things work well is to put a system in place and make it work for us. So we'll be calling on you. The PEEP group will not leave you alone now that you've told us we can make billions once we start listening to you. But I don't like to read, so we will need you in person to come and help us. I have a question though. So you left Cross Rivers in 2004. What is happening to what you put in place? Because Nigerians, I'm sorry to say, are quite difficult to get to toe the line. How have things improved, changed, remain the same? What's been happening? And then we'll open it to everyone to please ask your questions. I don't know how long Dr. Litu wants to give us, but this is an important topic and we should listen.
Thank you very much, Lisa, for those comments and for the question. It's a very, very important question because as we know in our country, one of the diseases that afflicts us is lack of continuity. After I left office in 2008, the first 3 commissioners that came after me, they left because before I left, we had succeeded in creating a department of clinical governance in the Ministry of Health. So it has a line budget. And I ensured that it has about 27%, almost 30% of the budget of the ministry on clinical governance. So they did not kill the department because they know if they killed it, they will lose 30% of their budget. And it's not easy to create a new department. So what they did was they just left the department there in abeyance, and what we started was just hanging around. But I'm glad to say that the current commissioner, who was the 4th after I left office, I was in London when she called me and she said, Oga, please can we meet? I said, I'm in London, in Calabar. So she said, oh, I said, what is it about? He said, the staff have said to her that there was something that was started some time ago that was very useful, and that was what helped them to deliver the kind of care that everybody was proud about. So she called us back. She called HRI Global back, and we are operating the program is called Reactivation of Clinical Governance in Cross River State. It's helping to revive those things I mentioned about. But then that's how Nigeria works. One person comes and wants to pull down everything the other person has done, which is not useful. So luckily, there's the reactivation of clinical governance in Cross River State.
Right.
Yes.
So we have our teacher, our former Minister of Health, Professor Nike Grange. I can see her hand up. And she's, she's an administrator par excellence. Would like to hear your comments now. And if you have any questions.
Yes, I have mostly comments and possibly one question. Professor Anna, thank you very much indeed for a paper that reminds us of our limitations as medical professionals in a country where health is not really prioritized. That really is a summary of what is happening to healthcare delivery. There is no prioritization of healthcare delivery. Starting with the Constitution. The Constitution puts health on the concurrent list, which means that the states really are the ones that are supposed to look after healthcare. Never mind having ministers of health and all sorts of other supportive officers at the ministerial level, most doing nothing that will make any impact. So that is the biggest problem that we have. And I am, your own report of what you've been doing at state level really testifies to that if you want to set up a good healthcare delivery system, you have to start from the ground level and hope that you can sustain it. And I must congratulate you for putting into your structure a feature that should help to sustain it. But as you yourself have said, even that feature was highly threatened, because the commissioners coming after you were not really, they did not buy into your vision. So we've got, this is the basic problem that we have in Nigeria. The other thing is that what you found in 2004 is an indicator of how the health system developed. Health system was basically initially just for the civil servants until long after independence, when hospitals started springing up right, left, and center. There were very few hospitals, and there were few quality hospitals. I think there was supposed to have been one Catholic hospital in Abeokuta, which is still there actually, by the way. And that's a private, semi-private hospital. So the way the whole thing developed, really will tell us why we are still where we are today. My
Okay. She frozen.
Yeah, she froze up, yeah.
now retrieve your data.
Oh.
You can retrieve easily and use the data, because that will be necessary when you are monitoring and carrying out research. So that's one. Then the second one is, how do you think that you can scale up this wonderful process which you have established in several hospitals? How can it be replicated in more hospitals so that it will make a difference to our health?
Excuse me, Ma, you're frozen.
Yeah, I think the network is playing up.
And I don't think you had the first question either. She had a couple of questions.
He is
Okay.
a member of the Board of Trustees.
Prof, we've had a bit of a problem. With the first question, you were frozen, and with the second question, you were frozen. So if you could please proceed for us, ma'am.
Okay. First question has to do with data gathering, I think. Electronic. Do you have, are your hospitals using electronic data gathering? And also, are they now switching over to getting patients to register online, etc., etc.? In other words, have you improved the methodology of their having access to services? The second one is, how would you upscale this? How would you replicate the 12 pillars in other hospitals? I know we've done them in a few, but we want them to be so much that it actually, spreads throughout the country.
Yeah.
Do you have do you have a plan for that? Thank you very much. Then let me just quickly say that we have both been on a platform which is looking at the universal health coverage for Nigeria, and as a CSO, civil society organization, and that is where I met Professor Anna, and he is somebody whom we cannot do without on that platform. Thank you, Prof. And
Thank you, Excellency. Thank you very much.
Thank you for spreading the joy to us pediatricians.
Thank you very much for those comments. Yes, I appreciate the comments, Mona. Now, to the first question about gathering data, I was rushing, but I could say to you, yes, that if you take Lilly Hospital and the Capitol Hill Clinic, they have not only established electronic health records that enables to, in fact, but for the insistence of some of us old school, Lilly Hospital is in a position now to become totally paperless. But it's just some of us feel that you still need this paper hanging there somewhere, because from what I hear, the most sophisticated organization in the world, which is the American military, still has paper records. So it will be nice for us to, as we're embracing the electronic, to also keep that paper for the odd case where we need them, where the electronic fails. So they've not only established the electronic health records for patient details, there is also a communication. There's a link between that and all the other portals in the hospital, from the pharmacy to the lab to the diagnostic radiology. And in fact, it's also connected to management, so that the management can keep a constant, literally 24 hours eye on revenues. As revenues are coming and as expenditures are made, they can keep an eye on it. Because, as I said, the audit, for instance, is not just about hypertension and about clinical cases. There's also the financial audit, there is security audit, there's audit of everything that happens in the hospital. And that has been able to be linked up electronically in that hospital. So it is possible to do it. And frankly speaking, we went out to America and India to get some of those capacities to do it initially. We spent a lot of money, but it didn't work. Finally, we had to bring in experts within the facility itself to generate it. So it was developed by Lilly Hospital itself, and it's working very well. Now, about scale up. We scaled up first on the state level, the government level, to Bauchi State. And it wasn't difficult to sell it. And one of the first things that happened there really about making sure that healthcare was universally available was to buy into the health insurance scheme. So whilst many other states were ambivalent about the NHIS, Cross River State and Bauchi State bought into it. And it was possible to deliver, in Cross River, it was 3.1 million people. In Bauchi, it was 4.2 million that were assured of a package of care underwritten by the NHIS. Now, I know that the country has moved on to the state-based, community-based insurance scheme. I'll tell you right away, and I've said it at various fora, I don't think it's sustainable because these are all tiny mushroom insurance schemes, whereas the NHIS, or NHIA as called today, is a bigger umbrella. And anybody who understands managing risk, not only in healthcare, but in finance, will know that the bigger and the richer the insurance company, the better they can manage the risks. And so let's see what happens with the Nigerian one. But there are not more than 4 or 5 viable states in the country. How are they going to run this? Especially when the health facilities are not delivering. So majority of the population of the states are reluctant to buy into this community-based insurance. Even if you tell them it will cost just, in some states, it's 1,000 naira, like Cross River is selling. In Niger State, it's about 7,000 naira for 1 year. To begin with, that is actually not viable, but that's a debate for another day, you know? So to scale up, we're working with, until last month, I was still the chairman of the Nigerian Medical Association Standing Committee on Clinical Governance. I was in that position for 10 years. We've handed over. So we formed a group, HRI Clinical Governance Group, that is going to very soon begin a real major scale-up advocacy. And it's going to be not just for doctors. We're working with various states and working with the Federal Ministry of Health as well. But let's see how it goes. Things are very slow in our country, but hopefully we should be making impact very soon.
Hosanna, don't worry. PEEP is going to work with you.
Thank
and
you.
you will scale up our hospitals for us.
Thank you very much.
That one I am certain about.
Thank you.
They won. I must actually congratulate ourselves and our chairperson, because the one pillar that we have held on to in the last year is this pillar of education and training, where we're focusing more on educating ourselves. There is still the issue of training. CPGs, CMEs, we're doing that very well. But do we have any personal development plans? How can we go about it? All of this is an individual responsibility and not necessarily a global responsibility. As an individual, we all should understand where we want to go, how we want to develop ourselves professionally, and how to go about it. Does your research body, would you be able to support us in this way? So we have training and not just educate, talking about clinical cases. So clinical governance is not necessarily about, going back to medical school.
Exactly.
It's more about making sure that the service you're giving is standard, or better still, excellent.
Yeah.
So would you be able to support us?
Yes, we were able to do that because our faculty is multidisciplinary and global. So depending on what individual facilities want, we can provide that. Centrally, we coordinate what the faculty do and make sure that we deliver to client needs.
I saw Professor Fajolu's hands up. Ireti, you had your hand up earlier on. Please.
Yes, ma. Thank you.
And
My question has been
answered
answered.
Because you are in the public sector as well, and you probably
Yes, I am.
to borrow some of the things you've heard today and try and get it introduced. At least, I keep saying that where to start really is the curriculum, the medical school curriculum. I went to England as a consultant, and I was dazed at what they were talking about. I had no knowledge whatsoever about clinical governance. And the first interview I went for, they gave me a topic on incidents reporting and said I should present to the interviewers. The next one, they gave me a topic on PALS, Patient Advice Liaison Service. I had no clue. And you can imagine the effect it had on me at the interviews. So this is me going at a higher level into the UK and having no clue whatsoever. Where do you think, this will be for Professor Anna to answer, where do you think we should start to introduce this knowledge to our future doctors, nurses, pharmacists, microbiologists, just name it? That will be a question for Professor Anna, but Dr. Fajolu, please, if you could speak.
Yes, thank you very much. Thank you very much, Ma. I want to really say a very big thank you to Prof for this excellent lecture. Clinical governance to me had been something that was just like a mirage, and him going through the story of it being feasible in Nigeria, I think is really, really something that we are proud of. And I think it's something worthy of emulation. And like Professor Grange said, there should be a plan to scale up to involve the whole country. I was worried about the issue of equity in healthcare. And I was going to ask the question about how they were able to sort that out. And he talked about the health insurance. But even as well as long as health insurance had been in Nigeria, we still have only very few of our patients having health insurance. So majority of them still come to hospital, even the government hospitals, without any money. So what they are able to access in terms of health still depends on what they're able to pay, because they now have to pay out of pocket. And that's one area that is still difficult for me to really, handle when it comes to patient care, even in the public sector. So I don't know how else other than encouraging, letting the insurance companies, reach out to the poor that actually need, not just leave it to governments, civil servants and people who have white collar jobs, if I can use that phrase. Thank you very much, sir. It was a very beautiful lecture.
Thank you very much. Thank you. Yes, could I say something now?
Yes, please.
Thank you. Yeah, let me deal with the first question first about how do we get this beyond what I would call the postgraduate level? How do we take it to, how do we catch them young so that by the time they graduate, they're already thinking about quality? Just like you, I know you said Nsukka is #3 university. If it wasn't that, that is University of Nigeria. That's really university in Nigeria. So they were not taught these things. And you come over to the UK, for instance, and then you find that it's basic. By the time the medical students graduate, or the student nurse, or the pharmacists, they already have concepts about risk management and quality embedded in them. So they don't have to learn it when they're in their residency or something, you know? So we've had interactions with the Medical and Dental Council, with the Nursing and Midwifery Council, and the board of the Community Health Practitioners of Nigeria. And we made most inroads with the Medical and Dental Council when I was a member of the council. And unfortunately, that was when Professor Roger Makanjola was chairman. So we tried to see if we could get this into the Red Book, which is the template for building curriculum for the various medical schools. But unfortunately, as happens in our country, that council was aborted midway. So we're still working with the current one to see if we can advance that to conclusion, so that it becomes part of the medical pre-basic training for medical students, for nurses, for pharmacists, for everybody. And that's why this group that we formed, the Clinical Governance Group, which I would share with you, is meant to drive it multidisciplinary, not just concentrating on just doctors, because in fact, the bigger work to be done in getting culture into practice, it's actually at these lower levels. So yes, we were working on that. About the health insurance, about getting universal health coverage and equity. We've said at various fora that if you look across the globe, only countries that have mandatory cover for all its citizens have achieved universal health coverage. And of all the developed countries, America is one country that hasn't achieved it, simply because it doesn't have that system in place. Sorry, I'm taking you back a bit. 1996, there was the Vision 2010. If you remember Vision 2010, late Professor Elebute, one of my mentors, was chairman of that subcommittee. The Nigerian Medical Forum was invited to make a presentation to that committee. We did. And we recommended to Nigeria, our country, that there are two health insurance systems in the world. There is the UK and European model, and there is the American model. These two classifications covers all the health insurance systems. And the difference is that the health insurance system in the UK and in the America has HMO. You don't have that in the other version. And the difference is HMOs are limited profit-making liabilities. Government has a social responsibility to provide health and education. This is as conflict with the ambition or the mission of the HMOs. So please, we told Nigeria at the time, if you want to adopt or start a health insurance scheme, which is crucial, don't go the American way, because you will only reap the fruit America is reaping, which is they don't have universal health coverage. And we went away. What did Nigeria do? Nigeria established the American model. And I can tell you that that is the bane. This is why the NHIS and now NHIA has been struggling. There's a conflict between that middleman, between the government and the patient, because their missions are different. So and this was why in Cross River State, we had to join the NHIS at the first opportunity. And we went to Bauchi State joined at the first opportunity, because we could see that that was the only way you can cater for majority of the population who are paying out of pocket, and it's pushing them into poverty. It's the only way. And the poverty has gotten worse, and it hasn't worked. So the solution is that let's see what the newly signed National Health Insurance Authority thing will do, because reading through it, I think they've sidelined the HMOs a bit. Let's see how it works. If they will have the political will to actually deliver on the letters of that law, it might begin to make a difference. So that when a patient comes to my clinic, the first thing that comes to my mind is not can they pay or can they not pay. The first thing should be, how can I help this patient, knowing full well that I can recoup my my expenses or my charges later on. I don't know if I've answered the question.
Thank you, Professor Anna. They've given us the opportunity to ask the final question, and then we will.
Thank you.
Dr. Ilitu will take over.
Thank you.
Dr. Odudu says, "Thank you, sir, for this wonderful lecture. One big change we face is the emigration of health workers, such that processes put in place are difficult to maintain and sustain because you barely train a set of people, they leave, and you begin again. What is your advice, sir?"
Yes, but I mentioned that we, in Cross River State, we had to match the teaching hospital by pay, take home. Because when we introduced all the other pillars of clinical governance, I discovered that each time there was a recruitment in the local University of Calabar Teaching Hospital, they took away all the staff that have been trained at great cost to the state. So that was enough evidence for me to gather and take to the political leaders and say, look, we're spending so much building capacity, training, and improving the outcome of the health system. Each time the teaching hospital recruits, I lose all the staff and I have to start all over again. So there is only one thing left. And what is that? We've got to match the take-home pay. There cannot be a difference between the teaching hospital and the state hospital, because if you take a nurse, a newly qualified nurse, for instance, employed by the state, their pay used to be like, they take home about 50,000 a month at that time. Their classmate equivalent in the teaching hospital was taking over 100 plus home. So why wouldn't they move? You can scale that up to outside the country as well. These are the factors that are pushing the people out. So going back to what Professor Grange did say, there has to be that political will to invest in health. But in my experience, a lot of work has to be done by us first to demonstrate to the public, to the government, that we can actually deliver quality care. As somebody said, this thing you're looking for in Sokoto, it's in our Sokoto. This thing, we can do it if you give us the resources to do it. And we had support both in Cross River and in Bauchi. In the private sector, it's not so difficult. It's not difficult to convince a good board of management or a good board of a hospital that this is the way to go. But for government, we really need to work in-house and reorientate those of us who are still on the ground to understand that we don't have, our brand is damaged. Our brand is damaged outside. We need to repair that brand as we are advocating for more resources. And that's what we did, and it paid dividends, especially because, 40% of our health budget, about 40% used to come from development partners. And it was the development partners, when they bring all these guidelines from Washington, from London, from where they expected that it will be localized and domesticated. And once they saw us doing that, every development partner in Nigeria at the time, the big issue was HIV and AIDS. Every single one of them came to Cross River State. So, and that means resources, especially for training and retraining, was really dealt with, So it's a multi-pronged approach, but if we're going to stem the brain drain, let's look inwards and see how we can improve on our output and our performance. And then we use that as evidence to convince the post holders that we can do this thing that you're going outside to go and do. We can do it in here, So
Yes, just one quick question.
yeah.
There's no doubt that financing mechanisms are really the key to establishing quality healthcare. Do you think that we should think in terms of having regional financing institutions rather than the federal? Because federal financing institutions have not worked well. The more money there is in the kitty, the more that goes out to, the more that gets lost. So thinking now about the political future of Nigeria, perhaps we should start thinking on zonal level for establishing infrastructures, and financing mechanism is one big infrastructure for healthcare.
Yes.
Professor Anna.
Thank you, Excellency. I think ideally, as I said earlier, the bigger the umbrella, the safer to manage risk, especially financial risk. The bigger the insurance, the deeper, the richer they are. But my colleagues, commissioners for health, used to say to me, why are you sending money to Abuja? The money should be coming from Abuja to you. I said, no, I'm not sending money to Abuja. I'm buying a package of care for Cross Riverians from a bigger insurance. Because we had done our actuarial studies. And when the opportunity came to go to Abuja and listen to the Professor Yuta Yalambo's team, I could see that it would cost us 4 times more if Cross River State went alone to create an insurance system than it would cost us from buying into the NHIs at the time, which was why we bought into it straight away. And since that time, the economic circumstances of the states have gotten worse. Just yesterday, I was looking at a chart of the indebtedness of the 36 states and FCT. It's incredible. It's incredible. I could see states that in 2008 were owing 45 billion. Today, they're owing almost 200 billion. So little wonder they cannot pay salaries, they can't pay pension, they can't do anything. So to now expect that they will be able to fund a health insurance scheme for their staff, for their population, it's going to be tough. It's not workable. It's not workable. It's going to be very tough. Maybe a few states, even that, it requires very strong political will to make that kind of commitment. To be able to pay the teaching hospital and the state, Cross River State staff, health staff, the same as their teaching hospital counterparts, my ministry budget had to go up by 2.1 billion. but we had enough evidence to convince the governors, both Governor Duke and Governor Lelimoke, that this was a worthwhile investment, and investment was made purely because they could see the output from the health system. They could see that the patients were happy with us, the public was happy, and the public, these are their electorates, so they were happy to make this investment. My colleagues were not happy in the cabinet, but I got it.
Were you happy with their level of transparency and accountability?
That is one thing that helped us. 1 year after the Essential Drugs Program, the MDs and CEOs of the 10 pharmaceutical companies we were working with in the Essential Drugs Program came to Calabar. We had a meeting and they said two things to me. Mr. Commissioner, one, you pay us as and when due, so we don't have to go to the bank to get extra we don't have to mark up. Two, they said this to me, your staff do not take bribe. 10 CEOs and MDs, your staff do not take bribe. And it was very heartwarming. And for that reason, the 10 of them, these 10 from Neomed to GSK to Mayan Baker to Enzo, all of them, they gave us drugs at, they call it level 4 pricing. That is the least level they can go and not make profit. So that was the level at which they supplied Cross River State Essential Drugs Program. And that was what enabled us to supply people who are coming from our area market on Onitsha Bridgehead to our Essential Drugs Program to buy drugs rather than go to Lagos, because it was nearer. So it is possible to effect this. It's possible to do it. And that's simply because the leadership right from the governor down, well, you know what will happen to you if you tried nothing else. So, and it worked. It worked. You know? So,
Thank you so much, Professor Anna.
thank you.
I did say at the beginning that you were not just a clinician or a surgeon. You have opened our eyes to administration. You've opened our eyes to some financial management. You've opened our eyes to the big issue of clinical governance. We are extremely grateful for your time.
Thank you.
And for the wisdom you've given us this afternoon. We will call on you.
Thank you very much.
As for the issue of brain drain, it is a massive topic. It's not just a question of cash. It's a massive topic that maybe Dr. Leto would like to look into some other time.
Yes.
So I will hand over to Dr. Leto at this point in time. Thank you very much. We really appreciate you.
Thank you. Thanks for having me. Thank you very much. Thanks, everyone.
So Dr. Leto is going to talk now.
Thank you very much. Dr. Nifade, I'll take you up on the issue of brain drain, so don't worry.
She's one of them. She's one of
Exactly, ma. Well, before I say the last words, I would like Dr. Bolaji Lawal to kindly respond.
Yes, just to thank Professor Anna very much for this lecture. Very, very authoritative and clearly given to elucidate a topic that frightens some people, and to show us that you can domesticate it and practice it locally and get results. And also Dr. Nifade for ably moderating the session, and also for the comments, especially for the past Honorable Minister of Health and other members who have made contributions and questions. It's been a very quality session, and we can go on till the next day. I'm only very happy that because you see, recently this group set up a team to educate pediatricians by way of continuing program further on this area of non-clinical continuing professional development. And Dr. Onifade happens to be the chair of that group. So I'm very happy that he has established that link with you. We were trying to get help from abroad, but I think that with this link, which I'm very certain she's going to pursue further, and I'm also happy that you have taken it on, Professor Anna. I'm very happy that that linkage has been made at this meeting, and I look forward to our further interactions with you. Thank you very much indeed, and thank you, everyone. Over to Dr. Leto.
Thank you.
Thank you very much, sir. Dr. Onifade, I want to say a big thank you. I know that we've had this discussion, like Dr. Mbolaji Lawal said, and we've had a few meetings to discuss how to improve on our training programs. So start thinking about your lecture on brain drain. Thank you. And to Professor Anna, I want to say a big thank you. Pardon the fact that I've been buzzing you and calling, and I'm sure you will understand why all of that happened, because what you've given to us today, I'm sure if we were to pay for it, I know how many dollars will have come out from our pockets, individual pockets. Thank you so much. And the link that we've established, we will continue to interact with you. And at some point in time, I'm sure you will talk to us again, particularly about financing, because I'm sure that's one area most of us will want to tap from your experience. So thank you so much. And I hope you're enjoying your Obudu trip, like Dr. Mbolaji Lawal said before, before we came on board. So thank you so much, sir.
Thank you.
And, to all those who have participated in the program, I say a big thank you. And our next meeting will be on the 27th of October. And it's one topic that I'm sure a lot of us will be interested in. I will not mention it until a few days to that date. We expect a very interesting presentation from one of our young upcoming pediatricians. Thank you so much. God bless. Bye.
Thank you. Thank you. Thank you. Thank you. Bye-bye. Thank you.
Thank you. Bye.
Bye.
Bye. Bye-bye. Bye-bye.
Bye-bye. Thank you.